So what I decided to do is just take some, and sorry Shana, I missed your talk, so I couldn't use what you were saying. Maybe I can use the passion in my talk, and that'll be what I've heard came from Shana's talk. But there were some common threads that I heard. One, that we need to allow the individual space to share their narrative, which I think is really, really important. What the person feels is important, validating their experience perhaps. Their expectations and the context in general matter. You can probably hear who these come from. Being kind to ourselves translates back to the person in pain. And pain is more than just what goes on in the brain. So what I decided to do was take my talk, my ideas about my title, and see whether we can weave a common thread from yesterday into my talk. So I'm going to just start with the first person phenomenological experience. Now that's difficult to say in the evening, a little bit easier now, but the narrative, the journey of that person in pain. And Maxi yesterday gave us a couple of, I thought, really tremendous ideas. Being open, make room for the story. And for those of you who listen carefully, open your ears and shut your mouth a little bit. I mean, we really do hear some tremendous stories, don't we? The narrative that they offer us. It can be quite upsetting as well at times. But it's important to give them time. And my experience of someone who has persistent pain is that they probably need a little bit more time as well to offer their story back to you, to be able to open up and get comfortable as well within that space, which takes a huge amount of consideration, care, and also practice as well. What Karen told us is pain is what you say it is. We do a couple of different exercises on various courses discussing what we think pain is. And it's a subjective experience. It's something we can never truly understand what that person is experiencing. It's inside of them. It's their first person experience. We try and measure a pain experience, and we can do that on subjective scales. We can try and quantify those scales as well, can't we? And we were listening to Karen talking about biomarkers, and I thought it was really interesting how she was saying, you know what, we need to be really careful about using these biomarkers as a diagnostic for pain. You said it was being temperamental. It's because I've fiddle around with stuff. So I was going to start with the first person. I've loosely called this selfhood. Selfhood is a constellation concept that involves not only representation and control of physiological homeostasis, but also the experience of owning and identifying with a particular body. So those of you who heard Antonio Damasio yesterday morning just started to touch on stasis, didn't he? And there's something interesting for me here is that there necessarily needs to be a body involved in the pain experience as well. So when you, and some of you were here on my class Tuesday and Wednesday, it seems absolutely ages ago now, doesn't it? We were pulling apart different pain models, and what we found from those pain models historically is that they were exploring pain but separating the person out from a pain experience. So going through historical models of pain, people were really interested in the tissues, but at the expense of the rest of the person. Then the attention started to move towards the spinal cord and the fact that we might be able to modulate sensory experiences. And then at the moment, we're in a sort of brain age. But what's interesting for me is we're just at a cusp now of saying, do you know what, maybe we're a bit more than that. So it was wonderful hearing Karen saying we're more than a brain, or pain is more than just what goes on in the brain. So I want you to just think, at the moment, how does your body feel? Before I said that, was anybody aware of a particular part of your body? And if you were aware of a particular part of the body, why was it that you were aware of that part of your body?